More than 200,000 people are diagnosed with melanoma every year in the United States. In fact, melanoma is the most dangerous form of skin cancer. There are all kinds of treatments being tested, including something called immunotherapy. Bench to Bedside starts now.
From the research bench to the patient's bedside, this is Bench to Bedside with your host, Vice Chancellor and Director of the University of Kansas Cancer Center, Dr. Roy Jensen.
Good morning, and thanks for joining us on Bench to Bedside this Wednesday morning. I'm Dr. Roy Jensen, Vice Chancellor and Director of the University of Kansas Cancer Center. Melanoma, believe it or not, is the least commonly diagnosed type of skin cancer, but also the most deadly. However, reported cases have increased steadily and rapidly in recent decades. Only 20 years ago, the average life expectancy of people with advanced melanoma was just 6 months. That is changing. Through advancements in treatment, including what's described as supercharging your immune system, people are living longer. Immunotherapy stimulates a person's own immune system to recognize and destroy cancer cells more effectively. And joining me this morning to talk about immunotherapy as a treatment option for melanoma and the different clinical trials underway here at the University of Kansas Cancer Center, and why side effects are actually a good thing for patients undergoing treatment, is Dr. Gary Doolittle, medical oncologist at the University of Kansas Medical Center, and Dr. Luke Selby, surgical oncologist and assistant professor of surgery at the University of Kansas Medical Center. And also Don, a patient who joins us via Zoom. Good morning to you all. And Don, I'm going to start with you. Don, you were diagnosed with melanoma, and now you are a patient of Dr. Doolittle and Dr. Selby. Tell us how you found out that you had melanoma.
Well, I went to my regular doctor a couple times last summer, and I had this mole on my neck, and one time I was itching it and it bled, and then I thought I got to have something done. So I went to my doctor and he cut it off, and 2 days later it was melanoma.
All right, so Dr. Doolittle, let's turn to you. How does one get melanoma? Is that sun exposure, or is there a genetic component to that, or both?
Actually, it's both. We know that certain people are at risk for developing melanoma based on their physical characteristics. So blonde-haired, blue-eyed patients that don't tan tend to be at great risk. Patients that have a family history or those that have had multiple moles, 50 moles or more, are at greater risk. Then you couple some of those risk factors with the sun exposure history that a patient has. We know blistering sunburns result in melanoma sometimes decades later. So we're always talking about the genetic makeup and a risk that you may inherit from your parent or parents, and also the sun exposure factors involved.
Mm-hmm. So there are different so-called stages of melanoma, and stage 4 means that the cancer has spread to other parts of the body from the skin. And right now, one of the best treatments for this disease is immunotherapy and surgery. Could you explain how treatments have advanced over the last few years in that regard?
Sure. I think that one of the paradigm shifts in the treatment of cancers, many cancers, is actually the introduction of immunotherapeutic agents to the clinic. These drugs themselves don't have anti-cancer activity, but they do stimulate the patient's own immune cells to fight cancer. And it's completely revolutionized the way we treat widely spread melanoma. I think in the literature still, and I think if we get on the internet some, we still find really negative statistics regarding the the higher stage or stage 3, stage 4 patients. And some of that's because these new therapeutic advances just haven't matured to the point where we're starting to see them commonly on a website. If you go to nci.gov, it's really up-to-date information, but others may not be as accurate. Having stage 4 melanoma isn't what it used to be, and we really encourage patients to come in, get their immunotherapy, and let them know that it's realistic to control the disease, and it's realistic to hope for a remission. And hopefully in the next 5 to 10 years, we're going to have some data that will tell us about cure rates.
Mm-hmm. So I think some people might be surprised to learn that losing the pigment in their skin may be a side effect of some of these treatments. Could you talk a little bit about that and why that may not necessarily be a bad thing?
Yeah, good question. I think with immunotherapy, the advantage is these immune cells are stimulated, they're activated, and the idea is that they will seek out the cancer or the melanoma cells and kill them. The challenge with immunotherapy, though, is those same cells can react against normal body tissues. So you can wind up with a rash, you can wind up with colitis, hepatitis, multiple side effects. And one that's really prominent is a syndrome called vitiligo. And vitiligo is when patients lose the pigment in their skin. And particularly if you're African American or you're a person of color, it's very noticeable. But even in the Caucasian population, we see this, and that may not be a welcome event for a patient, but for melanoma doctors like us, we like vitiligo because that's telling us we have an activated immune system, and that same activated immune system that's causing the depigmentations also working against the melanoma.
Mm-hmm. So Dr. Selby, you are a surgical oncologist, which is basically the 50-cent phrase for saying that you're the one who's responsible for cutting out the melanoma. Could you tell us a little bit about the surgical procedures and techniques that you use to treat this disease?
Yeah, so the goal of melanoma surgery when someone comes to me is partially treatment and it's partially diagnostic. So the treatment part of surgery is we're going to talk about where the melanoma is located on their body, and depending on some tumor characteristics, how much normal skin around the melanoma I have to remove in order to give the patient the best chance of cure. With that comes some questions about reconstruction. Obviously, removing skin off the trunk and removing skin off the arm are a little different, but we'll handle those conversations in clinic. And then the diagnostic part, the two greatest risk factors we care about for melanoma are the depth of the melanoma when it's diagnosed, so how thick it is in the skin, and then also whether it has spread to lymph nodes. And so depending on the same tumor characteristics actually that guide our decisions on margins, we'll discuss whether or not to do a sentinel lymph node biopsy. And then all of these conversations, we all work as a team. So I'm the surgeon, Dr. Doolittle's the medical oncologist. But anytime I see a patient who I think they might need Dr. Doolittle, or Dr. Doolittle sees a patient and he thinks maybe they need me first or they need me second, we talk to each other. We all talk probably most days out of the week. I'm talking to Dr. Doolittle about a patient.
So just to follow up on that very point, melanoma is a great example of how important it is to have many experts from a variety of different disciplines coming together to design the optimal therapy for a specific patient. Could you, both of you, tell us how that process works, how you come together to optimize that therapeutic approach for each and every patient that you guys see in the clinic?
Let me start, Luke.
Yeah.
I think it's really important from a medical oncologist perspective to be working with a surgeon that has a broad knowledge of the melanoma or the cancer itself. I do not practice in isolation. I can't do what I do if I'm not practicing with Dr. Selby and if we don't have a good working relationship. Because it's just so critical. This is a surgical disease. You know, I talked to you about immunotherapy, but this is also a surgical disease. And so that role is just critical for me, along with pathologists and radiologists and others that participate. But what would you say, Luke?
Yeah, I think the most important thing that I think a surgical oncologist brings to the treatment of melanoma is some of it is the technical expertise, knowing how to take out the melanoma, knowing how to do a reconstruction if it's in a complicated area. But it's also the fact that Dr. Doolittle sees himself as an oncologist who happens to treat cancer with medication that goes to the entire body. I see myself as an oncologist who happens to treat cancer in the operating room. And so we have largely a shared vocabulary and a shared approach to the treatment of disease. It just turns out that I cure melanoma with a knife and Dr. Doolittle cures melanoma with immunotherapy and other medications.
So Don, from your perspective, could you tell us a little bit about the experience of working with a team of physicians and specifically Dr. Doolittle and Dr. Selby on participating in this path to therapy for your particular disease?
Yeah, well, obviously, when you get this kind of diagnosis, you are shook a little bit, and meeting the care team, meeting Dr. Doolittle, Dr. Selby, Kristen, the nurses, it's just such a settling thing that I have such wonderful people to work with, and I've kept a positive attitude and just feel like I've got the best people around. I can call them anytime. I can get on my chart, and they'll be back to me that same day. It's just been a good experience for me.
So in our pre-show discussion, both of you talked about how treatments that you're currently using in the clinic either did not exist and were certainly not in the medical textbooks when we were all going to medical school. Could you explain a little bit about why that is?
Yeah, it's just that the immunotherapy that we use and other medications that we use are effectively brand new. I went back several weeks ago and looked in the foundational pharmacology textbook that I saved for medical school, looked in the foundational immunology textbook that I saved for medical school, and the immunotherapies, they're just not there. When I was a medical student and I was in the operating room and we were operating on a melanoma and the attending surgeon I was with would be asking me questions about it, the answers to those questions then and the answers to the questions that I expect our medical students to give me now are totally different. And so it's incredibly gratifying to have a patient who comes to us, has just found out they have melanoma, has done some reading and almost inevitably has found some information that's several years out of date and thinks need to have a very different conversation than the one we get to have. And so it's really gratifying to be able to help them through that.
I think it's fair to say when I was fortunate enough to be able to limit my practice to the treatment of malignant melanoma, I was really more of a palliative care physician, more of a hospice type of physician to those that had higher stage disease. And that's just not the case in 2022. We expect to control the disease. We hope to get the disease in remission. And again, we're waiting on the data, but we'd like to be able to say what the cure rate's going to be with some of these new agents. And we're a couple of years away from that, I think.
So if you're just joining us, we're here with Dr. Gary Doolittle and Dr. Luke Selby, and we are talking about melanoma. Remember to share this link with people you think might benefit from our discussion. Use the hashtag #BenchToBedside. And as always, Alexis Del Cid joins us now in the studio with a look at some of the questions that the community is asking. Good morning, Alexis.
Good morning. One of the big questions that we always get from our viewers, and we all have this question anytime we talk to a doctor about the skin, is there a certain ingredient we're supposed to be looking for when we get our sunscreen? And is there an ingredient that's not supposed to be on that label that's dangerous for us? Start with Dr. Selby.
The most important thing about sunscreen is high SPF sunscreen, reapplying it, especially if you have my hairstyle, wide brim hats. And, I'm not going to tell you to stay out of the sun. I don't stay out of the sun in the summer, but I am going to tell you that you need good sun protection. And as a consequence of that, you also need to keep track of your vitamin D level, because we get vitamin D from the sun. Vitamin D is incredibly important. But the most important thing about sunscreen is high SPF, reapplying it every couple hours. I tell all of my patients 50 or higher, reapplying it every 2 hours.
Is there an ingredient, Dr. Doolittle, that we should avoid? Because every year we get these articles that come out.
There's some controversy about this. We talk about sunblock as being a barrier block versus a chemical block.
Okay, physical sunscreen versus chemical sunscreen.
Right.
Yeah.
And at least when we were kids, maybe not so much for Dr. Selby, but it was zinc oxide. It's like this white paste that you put over your face to prevent sunburns, and those are still really good agents to use because we know you don't absorb them. And a lot of parents have this question about chemical sunblocks, and do any of the chemicals get absorbed, and what does that portend for the future of their children? So we usually encourage them to use barrier blocks. Titanium dioxide is another barrier block. So if you look at the labels, it'll show that. I couldn't agree with Luke more in terms of make sure you reapply. I'm great with that first application, but the second one, 2 hours later, I can sometimes get myself in trouble with.
I have a question for Don. If I can ask Don, we've heard the doctors talk about how it can be genetic, or you can be predisposed to having skin cancer if you're fair complected, or maybe you didn't wear sunscreen. Do you ever look back and think of anything when you were a kid growing up that might have contributed to this, or is it just bad luck?
I have fairly dark complexion, and I have never burnt in my life. I'll get red, the next day it's brown. So I thought I was kind of immune to this thing, but obviously I found out different. But no, I never wore sunscreen ever in my life. I was out in the sun all the time, and that's what it is.
And I think that's the lesson. I mean, I'm the poster child for what it looks like to be high risk for melanoma, and I now am much better at wearing sunscreen than I was when I was younger. But even if you have much darker skin than I do and a much different complexion than I do, you're still, if you're not wearing sunscreen, if you're not wearing a hat, if you're not, doing all the things we talk about, it does put you at very high risk. And we're talking about how we've changed the treatment of melanoma, and we're able to control and cure a lot more than we used to. But the best way to not get to meet me is to wear sunscreen.
Right. And Don, we got to cut you some slack here, because we didn't even have sunblock when we were growing up, right? We had zinc oxide and that was it. I honestly think today's parent is much better informed. They're much more careful about their children, maybe a little bit more careful about their children than they are themselves. So again, couldn't agree more with prevention is really key if we're going to control this disease over the long haul.
What you're saying actually goes along nicely with Jenny's question. Jenny wants to know, you talk about the best way to treat this is to not ever see you or meet you guys in person. Jenny wants to know, what do you do though? How do you treat melanoma when you catch it early, real early?
So, as Dr. Doolittle said, melanoma, especially when it's caught early, is a surgical disease. And so depending on the nuances of who diagnoses it, where it is, and how deep it is, it can either be fully excised by your primary care doc, by a dermatologist, or by a surgical oncologist. And that, when I'm talking to my medical students, we go on this for hours and hours. The thing to remind everyone is that the biopsy that diagnoses melanoma is never sufficient to treat the melanoma, even if it just requires another surgery. My favorite pathology report after I have excised the melanoma that was diagnosed, my favorite pathology report is that there's no melanoma in the specimen. That doesn't mean we didn't need the surgery. It just means we're really, really happy that we're done, and we, for a thin melanoma like that, we'd have every expectation of cure.
I also think it's really important to emphasize Dr. Selby's background as a surgical oncologist. His focus is the treatment of malignant melanoma, and for somebody like me as a medical oncologist, that's a really important piece of this. Not all surgeons know the literature in the melanoma world the way a surgical oncologist does, and the way Dr. Selby does as his focus is melanoma.
So, Dr. Doolittle, there's been a huge amount of progress in this disease, largely due to clinical trials and clinical research. Let's talk a little bit about some of the clinical trials that are now underway, one of which involves comparing surgical techniques in terms of when you begin immunotherapy. Do you do that before or after the surgery?
Right. That's a really good question, and we're working hard to figure out the answer to that question. For the longest time, the patient would be diagnosed with melanoma and then go straight to surgery. And even patients that we knew had disease that had spread beyond where it first started, either in the regional lymph nodes or through the body. And now we have a question about when we start the immunotherapy. There have been some smaller studies telling us that you could actually live longer and better if you start with immunotherapy and then go into surgery. But they're small trials. They haven't been verified in a larger clinical trial setting. And sometimes when you get a real positive trial like that with a smaller number of patients, when it comes to a larger trial, we find out the advantage isn't there. So both Dr. Selby and I are participating in a trial in which patients either start with immunotherapy, 3 different cycles, or they start with surgery. And as this trial matures over time, we'll actually be able to answer that question.
So, Dr. Selby, would you like to give us your perspective on that trial and how you think that this might operate?
Yeah, the theory behind taking out the melanoma first is that the melanoma is there and let's get it out. The theory behind giving some immunotherapy first is the immune system's entire job is to find something that's going to hurt the body and get rid of it. And so if now that we know immunotherapy works as well as it does, and the lymph node is the part of the body whose job it is to teach the immune system what's going on, we think, and as Dr. Doolittle alluded to, there's small preliminary data suggesting that patients who get immunotherapy first get their immune system turned on and then get surgery to go in and take out the melanoma do better. But again, we don't know the answer, and it's our responsibility as oncologists, and what sets the KU Cancer Center and places like it apart is the ability to come here and get one of 2 treatments that we know work really well, get the right treatment for the patient, but also then allow the patient to help further treatment for the melanoma patient diagnosed 2, 3, 4 years down the road.
Right. I actually think that's a really good point. Every drug we have in the clinic at one point or another was studied in a clinical trial setting. So every drug that is available for us to use actually has because a patient agreed to participate in a trial, because physicians before us agreed to open the trials and have them available. So it's really, I think it's really important that patients have these options available to them. Clinical trial isn't for everyone, but it is how we advance the field. And like I said, we wouldn't have the agents, we wouldn't have immunotherapy now if patients and physicians weren't willing to work toward that effort.
So given this variety of options for treatment, what kind of questions do you usually get from patients who are coming in to see the 2 of you in regards to helping them make a decision of which way to go?
Right. I actually think at some point higher stage melanoma patients, stage 3 or stage 4 patients, will be going to immunotherapy at some point. Early on, we may use specific drugs that are targeted for patients that have specific mutation changes, like BRAF is a driver mutation for melanoma. But any patient that has higher stage melanoma is going to come to immunotherapy at that point. And the questions they're going to ask are honestly really genuine. How do we take it? We give it intravenously. What are the side effects? How many treatments am I going to have? And we really have to spend a lot of time explaining what all those different scenarios will look like so the patient's well informed when it comes down to therapy.
Mm-hmm. So one thing that I've heard both of you talk about is the importance of, kind of remaining optimistic during your course of therapy. Could Dr. Selby, could you maybe talk a little bit about that and why you think that is such an important part of the process, so to speak?
Yeah, again, I think a lot of our optimism comes from the fact that melanoma, the treatment has changed so much in the past couple years. And so we're able to have conversations with patients that we weren't able to have several years ago. And on the converse, we're some of the more challenging conversations in oncology we're either not having or we're having much later. So we're able to get patients much more time. And again, it's not that these immunotherapies and the target therapies that we've been talking about, it's not that they're the only things we have available and there's nothing more coming down the road. There's lots and lots that's unsaid in this conversation, that other clinical trials we have, other medications where we will be opening clinical trials in the future. So in melanoma and in lots of cancers now, the 6 months or a year or 2 years that we're able to push off a disease recurrence with the medications we have, not only is 2 more years, but it's a really high likelihood that 2 years from now, there's going to be another new medication open that's going to get us some other amount of time. So it's certainly scary, right? I'm a cancer surgeon. Every patient who comes to see me is scared when they come to see me, and I get that. But it's a great time to be able to have these conversations because we can answer a lot of that fear. We can hopefully make the patient feel a little better, and we can promise them with a straight face that we're going to take great care of them and that we're hopefully going to be able to cure, and if not cure, push their disease down the road so that hopefully whatever immunotherapy 2.0 is in a number of years, we can get them there.
So another point that I think that raises is sometimes you have to have a conversation about perhaps reining the therapeutic choices in and talking the patient into doing less. Mm-hmm. Could you tell us a little bit about that situation and how those conversations go?
Yeah, so that's actually a lot of the conversations that Dr. Doolittle and I have are about trying to find a way for me to tone down the extent of the surgery that I'm doing. When I started my training, and I've alluded to this before, when I started my training, the medicines we had weren't very good, and so the surgery we used was much more extensive because it was the only thing we had. And I'm now here talking to you as a cancer surgeon about trying to put myself out of business and trying to do smaller and smaller surgery because we've learned and we're learning, and myself and other surgeons across the country are doing research trying to show that surgeons are doing research trying to show that we need less surgery because it doesn't benefit patients and because it's scary and all of these other things, and we have other stuff that can replace it. So there's nothing I would love more than sunblock and surgical de-escalation to put me out of work.
Yep. So if you're just joining us, we're close to wrapping up our discussion here with Dr. Gary Doolittle and Dr. Luke Selby. Remember to share this link with people you think might benefit from our discussion. Use the hashtag #BenchToBedside. And Alexis Del Cid joins us now. Do you have any more questions?
I do,
from Ron?
and I put my glasses on because this is kind of a doozy. It's about gut bacteria, and I want you guys to translate this to human speak for me. Okay, there's a new study that finds melanoma patients receiving therapy that helps their immune system kill cancer cells respond to treatment differently depending on the types of microbes in their gut. Are we talking about like when we're all advised to take probiotics and things of that nature? Can that help you?
Yeah, so it is really interesting. I think we're learning that the response to immunotherapy can be greater depending upon the bacteria that are located in the GI tract. And it's not all bacteria. There are certain strains that may have a more positive effect on the immune response, more positive effect on these drugs. In fact, we don't think that probiotics are the answer. Some of the studies have told us that patients haven't done as well with those, but again, some very specific bacteria that might. We also have a recent report that patients that are taking immunotherapy and consuming 20 grams of fiber or more a day actually have a better immune response.
So
it's,
fiber
yeah,
does it.
So everything that we've been talking about in terms of wellness, I mean, I think that's a piece that we're really trying to encourage our patients. It's good for wellness, but it's also, we think, going to make the immunotherapy work better.
So is there anything you can eat or drink that will give you that good bacteria if it's not probiotics? Like, how do we get it?
Yeah, good question. To my,
I mean, I think fiber helps
Fiber gives you
promote
that?
the right bacterial growth
Okay.
in your GI tract.
Interesting.
The other thing that I think a lot of people don't understand is that the small intestine and the large intestine are sites of some of the largest collections of immune cells in the body. And most people think it's limited to, say, lymph nodes and
Right.
spleen, but that's not true. The GI tract is a place where there's a very large number of immune cells, and it's becoming increasingly clear, I think, that the GI tract and the immune system work together to develop the appropriate immune response to a whole host of different agents. And the data that you just cited there is a great example of how it's pretty clear that that's how all this works.
It's super interesting. I have a question for Don. I just would love to know, Don, how has life changed for you, or has it changed? Do you still take vacations to Florida? Do you still go outside in the summertime? How has it changed life?
Well, being diagnosed last fall, I haven't gone through a summer yet, but spending 2 months here in Florida, it's been a bit of a challenge to stay out of the sun, but I buy these cool long sleeve shirts that have UV protection. I have a couple real cool wide brim hats. I play golf, fish. Not much.
That's good. So still able to live life and just take all the precautions that our doctors have been telling us we need to take.
right, and that was one of the things Dr. Selby was talking about. I don't think asking a patient to stay out of the sun makes sense, because there are too many things that we enjoy with our families. There's too much that goes on. I still like going to the lake. It's about doing what Don does. It's about sun protective clothing. It's about sunblock. It's about wearing caps to protect yourself from the sun. Go out, have fun. Just protect yourself in the process.
I think that's a great lead-in to the next question, which is, could you tell us a little bit about the melanoma survivorship clinic program, and what suite of services do you offer those folks?
Sure. This started now just a little over 3 years ago, and so many patients that are diagnosed with melanoma have a great prognosis. We always worry about those that are at high risk for recurrence, or those that have disease that spread, but many have a great prognosis, yet they still need to be followed in the clinical setting. So we started the survivorship clinic just to cater to that specific group. And yes, we do have surveillance work that we do to make sure that the original melanoma, if it recurs, we pick up on that. But we're also looking for the development of a second melanoma. If you've had one, you have anywhere between 5 and 15% chance of developing a second melanoma. The other piece, we're looking for late effects of treatment or side effects that may be picked up that haven't been described. And then we really want to focus on wellness too. Some of that is the sun protection we've been talking about. Some of it is, the proper diet, watching your weight. If you're a smoker, we want you to stop. Watch your alcohol intake. All those things that are part of general wellness that we really want our melanoma survivors to take advantage of.
Mm-hmm. So, Dr. Selby, you cut melanoma out on a close to daily basis. And that leads to my next question. How important is our biospecimen bank to our research efforts here at the KU Cancer Center?
So it's incredibly important. What Dr. Jensen's alluding to is when you come and see me, we take out a specimen, I send it to the pathology lab. The pathologists take the tissue that they need to make the diagnosis, so I can take care of you, or myself and Dr. Doolittle can take care of you. But almost always there's additional tissue left over. And if we were to do nothing about it, some of it gets saved in case we need to look back in the future. But the rest of it really would get thrown out. And what Dr. Doolittle has started is now with the biospecimen bank is all of that tissue gets saved. And it gets saved so that in the future, when we have a research question and we want to go back and the question can be answered with these specimens, we can pull it up and we can look at it, and research either that gets done by physicians at the KU Cancer Center or by researchers at the KU Cancer Center have access to this tissue. We know the clinical characteristics of the patient. Depending on how far out we are, we know by keeping track of them in the survivorship program, often we know how they're doing, and it allows us to answer a lot of questions. To circle back, immunotherapy exists because 20 years ago, 30 years ago, physicians and pathologists and researchers noticed that some patients in their melanoma specimens had a lot of immune cells in the specimen and others didn't. They made the clinical observation that those two groups of patients did very differently, and they used specimens to then tease out what was going on with the immune system. And we believe by keeping the tissue in our specimen bank that we're going to be able to perform, the similar research questions this year, next year, and 5 years. When the question comes up, we'll have the stuff to answer it. Mm-hmm.
So I want to get some final thoughts from all of you, and start with Dr. Doolittle.
Yes, thanks, Roy. My one message would be, let's really focus on prevention, right? We've talked about that this morning, and, sunblock, sun protective clothing, stay out of the sun when you can, right? But the other is secondary prevention, and by that I mean getting diagnosed with melanoma at an earlier stage. So if you have a mole that is changing, itchy, bleeding, different, do what Don did and get to your primary care doc, primary care practitioner, and have it addressed. Because there's no question, earlier stage melanoma, under the care of Dr. Selby, you've got a great chance of being cured with surgery alone.
Dr. Selby?
Yeah, the thing I'd like to tell patients is that, once you have the mole that you think is concerning, or once it's been biopsied and you find out that it's melanoma, get yourself to a surgical oncologist, get yourself to a cancer center, so you can get surgeons and medical oncologists who think about this every day, so your slides can be looked at by a dermatopathologist who's a pathologist who thinks about this every day. Even with how much we've been talking about melanoma, it's relatively rare, but the beauty of a cancer center like the KU Cancer Center is that we take diseases that are rare out in the community and we centralize them and we turn them so they're not rare. A place that can support a surgeon who everything that I do is melanoma. Probably 70% of my practice is melanoma. A medical oncologist like Dr. Doolittle, who everything that he does is melanoma. We have 2 dermatopathologists who all they do is look at skin. So when you are diagnosed, if you are diagnosed, come to KU or come to a cancer center like it so you can get the best treatment.
All right, thanks. Finally, Don, I want you to have the last word. Stage 3 diagnosis of melanoma can obviously be scary and overwhelming. What advice do you have for people facing a similar diagnosis to your own?
Well, first of all, I have a pretty strong faith, so I can stay positive that way. Another thing is, don't go looking on the internet. Trust your care team because they're the ones that know what's going on. All you're going to do is on the internet find things you don't want to see. Support group. I have literally hundreds of former students, former colleagues, old friends from classmates from high school, friends from church who all keep sending me positive vibes. And probably last and most important is my wife works for the University of Kansas healthcare system as a cancer registrar. So her knowledge and keeping positive behind me just really makes things good.
Great advice, Don, and yet another reminder that Dr. Internet has never cured a darn thing. So I want to thank all of you for being part of this week's episode of Bench to Bedside. To learn more about melanoma, please visit kucancercenter.org/melanoma. That's it for today. Join us next week at 10 a.m. for Bench to Bedside. Thanks for watching. Subscribe to our Bench to Bedside podcast, now everywhere podcasts are available.